So we shall be talking about mental health illnesses, how they impact on suicide, and possibly discuss treatment options and how to prevent suicide if it's possible, if we have the time. I know a lot of people have been crying of data, this, data, that, but we'll do what we can see what we can do. So we shall start by defining what suicide is, first and foremost. And suicide is when somebody takes their own life by themselves. That is what is suicide. When somebody kills themselves through processes like hanging, taking poison, jumping into Third Mainland Bridge, things like that, is what we refer to as suicide. There is also what we call attempted suicide, when people have maybe they wanted to kill themselves, or they harmed themselves in such a way that they didn't die, sometimes through taking overdose of medication, maybe inflicting injuries on themselves and things like that. We also have what we call assisted suicide, whereby even though the person took their lives by themselves, but they have an accomplice who possibly had them, giving them an advice on how to do it or provided the means for them. It is not that person, the other person, the third party killed them, but they took part. They were an accessory. That's assisted suicide, which is opposed to what we call euthanasia. Euthanasia is situation whereby somebody, actively killed somebody when the person wishes to die. So unlike in suicide where you took your life yourself, in euthanasia you went to somebody and said, I want you to kill me. And then the person probably will inject something that will kill you. In the UK, it's not legalized. People go to Switzerland, Belgium, and those places to pay a lot of money to be killed. Euthanasia, such a word. Okay, so for your to put it in perspective, suicide is very common. I think 1.5% of all death is from suicide, and it's commoner in the Western world than Africa, in the developing world. So we need to look into some of the causes of suicide, some of the things that cause, put people at risk of committing suicide. So before we talk about the mental health cases, possibly people die because of people commit suicide because they're in debt, they're heartbroken, their partner has left them, they don't have a job, they haven't got the money, all sorts of things, but most of the cases of suicide are linked to mental health illnesses. So before we talk about the mental health illnesses, substance abuse of alcohol, cocaine, Valium, what we call benzodiazepines, such medication also put people at risk of taking their lives. So a lot of people who use drugs, kill themselves. So let's talk about the mental health illnesses. There's quite a few mental health illnesses that put you at risk of committing suicide, and I will endeavor to discuss some of them. 50% of all cases of suicide are usually linked to mental health illnesses like depression, but I will lump them together as mood disorder. Mood, MOOD, your mood, disorders of your mood. And there are 3 types of this disorder that I will talk about briefly. One is depression. At the other end of the spectrum is mania, hypomania. And then we have in between what we call bipolar or manic depressive illness. It is called bipolar, two poles, Okay, so let's start by discussing what is depression. I hope you guys can hear me. So, depression is not just when you feel down or when you feel unhappy or when you feel sad or despondent. That is not just depression. Depression is a multi-systemic illness, which is a terrible one. So before anybody will be said to be suffering from depression, there are certain symptoms or certain complaints that the patient will be making, or certain things you will elicit when you assess the patient's mental state. First and foremost, those symptoms we're talking about must have existed for most of the time for at least 2 weeks for it to be significant. So it's not a case whereby, oh, maybe somebody woke up this morning and feeling low and you say, no, I'm depressed. No. So those symptoms must have existed for at least, most of the times, for at least 2 weeks for it to be significant. And the symptoms include, number one, you must feel low in yourself. You must feel down in the dumps. Your mood would be low. So you'll be feeling low most of the time for at least 2 weeks. That's a cardinal symptom of depression. The second cardinal symptom of depression is what we call anhedonia. Anhedonia means you've lost interest in pleasure. Nothing pleasures you. Nothing pleases you. You're not interested in anything. Whatever you used to enjoy before, you will not enjoy anymore. Maybe if you like swimming, you like singing, you like sex, you like anything, you lose interest in them. You don't care. You can't be bothered about anything. So that is called anhedonia. So for you to be diagnosed with depression, those two symptoms must be there: low mood and anhedonia, loss of interest. So there are other symptoms that are associated with depression. One, it could include things like poor sleep. You struggle to sleep, or you sleep, wake up, and your sleep is all over the place. Some people also oversleep in depression. So there are sleep disorders with depression. Also, your appetite, usually the appetite goes. You don't have appetite, you struggle to eat, you lose interest in food. But sometimes some people also overeat in depression. Also, in depression, people lose concentration. You can't even focus to watch this live session. You can't even read newspaper. Even watching TV, you won't be able to concentrate to watch it. So lack of concentration or poor concentration is one of the symptoms of depression. Also, poor motivation. You're not motivated to do anything. Maybe you say, oh, I'm going to tune into this live session. When it comes to 8 o'clock, you won't be bothered. You are not motivated to do anything. So that poor motivation is one of the symptoms of depression. Also, there's a problem with libido. A lot of people who are depressed have suppressed libido. They're no longer interested in sex. Their partners will be wondering what's going on. They don't want to have sex. It's not because they don't love their wives or their partners, but it's just because they're suffering from depression, so they can't be bothered. And also, a lot of them feel guilty. That some of them feel that they are a failure, they're a disappointment to the family, and then a lot of them think that life is not worth living again. And some of them contemplate hurting themselves, and at the extreme, some of them take their lives. And at certain, like everything else, depression has different levels of severity: mild, moderate, and severe. So in the severe cases of depression, people suffer what we call psychomotor depression. Psychomotor retardation, where they cannot even speak, they will not be able to walk. Movement is like they're so sluggish. If you ask them questions, they will just be looking at you. They can't speak. They will lie in one place. They will not stand up from one place for like weeks, And some of them start to hear voices. Nobody is speaking to them. They'll be hearing voices. The voices will be telling them directly, you're an idiot, you're stupid, you smell, kill yourself, useless. The voices will be speaking to you like that. This is, this type of depression we call psychotic depression or depressive psychosis. So they'll be hearing voices, they'll be paranoid, they'll be thinking, oh, everybody's talking about them. So this is the extreme of depression, which we call psychotic depression, and also psychomotor retardation. Some people also who are depressed could have psychomotor agitation, where they speak fast, they walk fast, but usually what we have is the reverse, where in severe cases they don't talk, they can't talk, they can't, they can't do anything, they won't drink water, they will not bath, shower, they will not comb their head, they will not change their clothes, nothing. They will just stay in one place and not eat nothing. They won't eat. Very severe. So it's quite a severe situation. We also have a variant of depression, which we call postnatal depression, which usually happens to women after childbirth, but it also happens to their husband. Some men also suffer from postnatal depression, though it's commoner in the woman who has had a baby. But postnatal depression is not the same thing as baby blues. Baby blues seems to be normal. It happens to most women after childbirth. The first 2 weeks of childbirth, they feel anxious, they feel unhappy. They're not, they can't be bothered about their baby. They feel angry and all that. So that's called baby blues. Usually within 2 weeks, that fades away and the woman is normal, back to herself. That's opposed to the postnatal depression, which starts usually much later after the baby has been born, usually from 2 weeks and later, where the person, the woman or the man, usually the woman, is depressed, lost interest in things, feels so down, is not bonding with the baby, not happy, doesn't like a baby, doesn't want to do anything, feels that they're not supported. And in extreme cases, they even, take their lives or even kill their babies. So it's called postnatal depression. There are also people who suffer from another kind of mental illness after childbirth, which we call puerperal psychosis, which, the woman becomes quite psychotic, with thought disorders, paranoid, delusional, and could, at the end of the day, kill themselves or also kill their babies. So the good news is that most of these conditions are treatable. So we've talked about depression. I will look at the questions asked and then respond to them, but I'm not going to be able to do them as I speak now. So like I said before, we're talking about mood disorders, your mood. So one of them is depression, which I have spoken about. At the other extreme of it is what we call mania. When you're suffering from mania, you're said to be manic. So while in depression, you're slow, you're sluggish, you hate things and all that. But in mania, you're on top of the world, you feel that you're the president of America. My name is Rosemary Chigo. I'm the wife of the president of America. I've owned a jet. I've got a yacht. You want sex all the time. You spend money. In fact, you spend money you don't have. You can come and say you're God. And in fact, you're a God. You're just flying. This is mania. You are manic. Every day you spend all the money you have. You want sex every second of the day. You're thinking that you have what we call grandiosity, delusion of grandeur. You feel that you're what you're not. You feel that you're you're Trump. You're this. You're that. You've got 2 billion in your account. Meanwhile, you haven't got anything in your account, but you actually believe you have billions in your account. So that is what we call mania. So where they also hallucinate, they also hallucinate. They could hallucinate. Usually they do have what we call visual hallucination, which where they see things that don't exist there. Things that are not there, they can see them. There's I can see this person here. I can see this person here. That's mania. So I've discussed depression. I've discussed mania. But there are also some people that suffer both of them. At one time, they are depressed. You see them next week, they're manic. Today, they're manic. Next week, they're depressed. These are the people they call bipolar patients. They are suffering from bipolar. Bi means two sides, two poles. One pole is depression, one pole is mania. It's also called manic depressive illness. So such people today, you see them, they've lost interest in things. They are not, they can't be bothered to take a shower. They are so withdrawn. They lose interest in everything. They want to kill themselves. They think they are a failure. Next week you see them, the same person will say, oh God, I'm just coming from America now. I just bought a Jeep. I just bought this thing. They start boasting. They start saying things, and they speak very fast. They have what we call flight of ideas from one thing to the other. They're talking about one thing. Before they finish talking about that thing, they're talking about another thing. They're talking about this one, and they talk very quickly, very fast, So the same person is suffering from this and that at the same time, but not the same moment. So maybe you see them on Monday, they are depressed. You see them on Wednesday, they are manic. That same person. So these are what we call mood disorders, the common mood disorders. Depression, where you're feeling low all the time, most of the time actually, you lose interest, you can't speak, you're not motivated, you're not sleeping very well, you're not eating very well, you don't have sex drive. That's depression. While the other end of the spectrum, you are manic, you want sex every day, you're spending money like mad, while bipolar, you suffer from both of them. So these are the common mood disorders that I wanted to bring to your attention. And these are some of the mood disorders that pose risk and make you susceptible to committing suicide, and many commit suicide. So there are also other illnesses, mental health illnesses, that would put you at risk of committing suicide, like schizophrenia, which is a psychotic illness where you have thought disorders, things like there's something we call functional thought disorders, like you think somebody can read your mind, or somebody is putting thoughts in your head, or people can hear what you're thinking. Like you think people are broadcasting, what you're thinking is being broadcasted. That's what we call thought broadcasting. Or you think that people are taking thoughts from your head. That's thought withdrawal. Or you think people are inserting things in your head. That's called thought insertion. And they're also delusional. Delusional is when you have thoughts or beliefs. You believe that they are real and genuine, but they are not, they're baseless. When maybe if you think that you are actually, you can heal the world, for example, when there's no basis that you can do that, or you believe that somebody is actually after you, when there is nobody, you can have, that's what we call paranoid delusions. So, such illnesses, there are so many symptoms of schizophrenia. I cannot go through all of them, but it's a kind of psychotic illness, which, so it puts you at risk of committing suicide. And even anxiety problems also put people at risk. There's something we call, there are different types of anxiety disorders. We have what we call generalized anxiety disorder, and then we have specific anxieties like phobias. But generalized anxiety disorders, when you're generally anxious over nothing in particular, and then, you have symptoms like palpitations, you're sweating, you feel panicky and all that. Some of these things put you at risk of committing suicide. So I know that you want to know whether these conditions are treatable, or, like in our place, a lot of people, I think the psychiatric services in Nigeria is, diabolical. It's not as good as it should be. So a lot of people take their, when people have all these mental health issues, they take them to native doctors, to herbal homes, take them to funny places and people get to die. But generally, treatment abound. And I would like to discuss some of the possible treatments that are readily available for these mental health conditions. So I will start with depression. The treatment depends on the severity of depression that you're suffering from. So basically, we have tablets, which we call antidepressants. Number two, we also have psychological treatment, which are not tablet based. Things like cognitive behavioral therapy, some kind of counseling, psychoanalytical psychotherapy, things like that. They are kind of talking therapy that help with depression. There is also something that we call shock therapy, where you are put to sleep, and then your pads are put on your head, and shock waves are put through your body, which we call electroconvulsive therapy, ECT. I will explain them. And we have the newer one, which we call transcranial magnetic stimulation, which is another new treatment that where something like a coil is put in your brain and your head, and then electricity is passed through it, and that's for you to be treated for your depression. So if you have mild depression, if your depression is mild, in the case that maybe you just feel low occasionally and all that, counseling and cognitive behavioral therapy, which is a kind of therapy that modifies your thought processes and all that, can work. They can work on its own, but I don't know how available those services, facilities are in Nigeria. I don't know where you're watching from, but if you're watching from advanced countries, they are there. So they work. And then if your depression is mild to moderate, you can have antidepressants, or you can have a combination of psychological therapy and antidepressants as well. Some of the common antidepressants are, in the olden days, we used to use the family of antidepressants called tricyclic antidepressants. Things like amitriptyline, nortriptyline, trazodone, and all that. They did a good job, but because of their side effect profile, they are no longer commonly used for depression. We reserve them for certain things, other conditions now, even though people who have been maintained on them are still on them. But they are no longer the first line. They're not the first medication we'll prescribe for you if you're depressed. We'll start with the ones we call SSRI. Some of them are, you will hear things like Prozac, things like Seroxat. I don't know what they call it in Nigeria, but their pharmacological names are like fluoxetine, paroxetine, citalopram, sertraline, escitalopram. These are the ones we call SSRIs. So these are what we normally start the patients on, and they're effective. The only thing is that they usually don't work quickly. They are not medication that you start today and then your depression goes the following day. Sometimes it could take, I've seen people, it takes a week, sometimes even up to 4 weeks for the effects of these medications to kick in. So you will need to take them regularly, you need to persevere, and they will start working. And when they start working, they work slowly. So you'll be having more good days than bad days, and eventually you have more good days and you start getting better. So most times you need to take them regularly for up to 6 months, and I've seen people who are on it for years. They haven't been able to cope without them. They are not addictive, but we advise that you don't stop them suddenly, because if you stop them suddenly, you may have a kind of withdrawal syndrome. And some of these antidepressants, this SSRI, when you start them, your risk of suicide is higher, especially in younger children, not in adults. So we are careful when people who are adolescent are started on these SSRIs. So they need to be observed. Close family people would have to be around them to stop them from taking their lives, because they feel more like doing that when they start those medications. Yeah. So when the SSRIs don't work, we also have another group of antidepressants, SNRI, things like mirtazapine, duloxetine, that we also use. We also prescribe for these patients. They are all readily available. They work. Some of them do have side effects, common side effects like headaches, dry mouth, constipation, things like that. But as you use them, your body gets used to them, and then they become normal. So when you're started, we normally start them on the low dose, and as you take them, we monitor you maybe within first 2 weeks of being on them and see if you don't have side effects, and if they're not working, we will increase the dose until we get to the maximum dose, and then we see how it's working. And a lot of times they work. So these are medications that you use for depression. In extreme cases, no medication works. And then you get worse, and you get worse, and you get worse, to the point that you are so depressed that you're hearing voices, you don't eat at all, you don't speak at all, you can't work, you're in no place. These are the candidates we consider for shock therapy, which I remember the days when I used to administer this shock therapy on patients. It's quite dramatic. We do it. They go into that shock therapy is called electroconvulsive therapy, where you're taken into it's like a theater, and an anesthesiologist would come and check you and put you to sleep, like as if you're going to have an operation, and then we would then bring the ECT machine, then put two parts on two sides of your head, and administer shock, through your brain, and then you shock. So we do several sessions, and I have seen many patients who, after the session, patients who didn't eat, who didn't shower, who didn't, after the session, they jumped up and started doing everything as normal. You would think, oh my God, is that the same person that was on this couch? So it is treatment available for such. But there have been an issue with that treatment. Some complaints that people after the treatment, they have a kind of cognitive issues. When I mean cognitive issues, they get a bit confused, after the procedure, and they're no longer as as smart or as sharp as they were before the procedure. So there's a new treatment. I haven't personally administered it, which came out, which we call TMS, transcranial magnetic stimulation, for also this depression. And it is basically doesn't cause some of these problems that ECT causes, and you don't need to be you don't need anesthesia, you don't need to be put to sleep to have this treatment for depression. It is not readily available right now, but I think it's available in America, some parts of UK, and all that. So these are all treatment available for depression. So we've talked about psychological therapy, counseling, tablets, which we call antidepressants, tricyclic antidepressants, SSRIs, SNRIs. These are all tablets that are used for depression. Electroconvulsive therapy and TMS. They are all available and they can cure your depression, even though in a lot of cases it's a chronic illness that keeps coming and going. They get better, they get worse, they get better, they get worse. I forgot to mention before I talk about mania and all that. So some people might be thinking, what causes depression? Is there do they have causes? We in the olden days we used to classify as endogenous and exogenous depression. There are some depression that has got no cause. You be rich, you're educated, you're happy in marriage, you have a very good job, and yet you're still depressed. So we have people that you can't explain why they are depressed. You cannot explain. There is no explanation whatsoever. While there are people that maybe because of broken relationship, because of poverty, because of pain, because of chronic illnesses, because of breakup in relationships, or things like that can, push people over to becoming depressed. So, like I said, those symptoms of depression that you have would have to endure for more than 2 weeks for you to say to be depressed. So, okay, so that's a little bit about depression. So we also need to talk about mania, which is the other spectrum of mood disorder, which I said before can lead to suicide as well, where the person is manic, spending money, wanting sex every day, thinking they are Jesus Christ when they are not, talking very fast, having flight of ideas. They're talking one thing and going over to the other thing. They're not completing one sentence, they're going over the other time. They have they exhibit delusion of grandiosity, where they think they are what they are not. They just feel they have superiority complex. They think everybody is beneath them. So this is mania. Obviously, we have treatment for them, which usually the antipsychotics are also used for them. Before we have things like Lagactil or those chlorpromazine and things like that. But these days we use novel medications like quetiapine, olanzapine, and the rest like that. And then we now have bipolar, which I talked about before, where one person is suffering from both depression and mania or hypomania. One person. Today you meet him, he's depressed. Tomorrow you meet him, he's manic. So the principle behind the management of that is to stabilize their mood. So they are put on mood stabilizers. Something to stabilize their mood. It's like stabilize electricity stabilizer. Like when you have low current and you still do have high current, you buy a stabilizer to stabilize your current so that your appliances will not blow. So when you suffer, so they give you mood stabilizer. In the olden days, we normally use only a medication called lithium, and because lithium causes toxicity and it needs to be monitored so much, we also now use as mood stabilizer even antipsychotics like quetiapine. We use epilepsy medication like sodium valproate, carbamazepine, medication that were originally used for epilepsy are used as mood stabilizer to stabilize your mood, and so that you'll be on even keel. You will not be manic and you will not be depressed. It's not a straightforward thing to treat, but it can be treated. So this is about mood stabilizer, while the schizophrenia is also treated with antipsychotics like I said before, quetiapine, risperidone, amisulpride, olanzapine. Some of them would need to go on injections, which we call depot, Depo injections, Depakote and Clozaril injections and all sorts of when we say Depo injections that you probably have to give once in 2 weeks or you have to give once in a month. They stay long in the system and they work, especially people who cannot take their tablets, who are not compliant. So you put them on these long-term injections that you just give them injection in their bum, once a month. And some of these injections, like some of these medications, need to be monitored. Also, you need to do blood tests. You need to do ECG. That's electrocardiogram, ECG. I don't know what they call it in America again, whatever. But ECG, to monitor them because of the side effects in the heart and all that. But they work. They work. I have, experienced, seen a lot of people who have these mental illnesses that have taken treatment and got better. So then we talk about, I've talked about, apart from the mental health illnesses, substance misusing of substances like alcohol, cocaine, Valium, medications we call benzodiazepines like Valium, diazepam, temazepam, lorazepam, things like that put you at risk of committing suicide. So these are some of the risk factors to committing suicide. And can suicide be prevented? Yes. It can be prevented if you have, first and foremost, good social network, people who look after you, especially who can tell when you are feeling suicidal. It's not everybody that commits suicide that talks about it. There are some people who call PD, people who got personality disorder, who always threaten, I'm going to kill myself, I'm going to kill myself. Anything you say, I'm going to kill myself. Some of them don't kill themselves, but some of them eventually kill themselves. So there are such patients, they have personality disorders. They can say to you, I want to kill myself. And then in good setting, like in the UK, if you threaten suicide, you would the system will be activated to stop you from committing suicide. Here in the UK, you can actually be sectioned. Section means you can actually be detained by a doctor, social worker, psychiatrist, against your will for assessment and also treatment. We call that Mental Health Act sections. So we have different sections of that Mental Health Act, And I remember when I was training, those days when I was a young senior house officer, every night police would bring in a patient who they brought from the street, under what we call Section 136. They will now bring them against their will to us, and then and then we would have to assess them and treat them against their will. Some people are kept for, something like Section 2. You can be kept for 2 weeks for assessment, and that can be extended. We have Section 3 where you can be kept for 6 months, and then you can be extended and be extended. It's like prison, but you're not in a prison. You're in a mental health hospital and kept there and given treatment against your will. That can happen in the UK. I don't know whether there are such facilities in Nigeria to treat people. I know they put leg iron on people in Nigeria and force them anywhere. I know they do things like that. But in the UK, there's a legal framework to treat you against your will. Because one of the hallmark of mental health illnesses is lack of insight. It means that you do not believe you're ill. You don't believe you're ill. It's the next person that is sane, watching you, that knows that you're ill. So you may not consent to treatment because of that lack of insight. So that's why you're detained